Thank you so much, Sherry. And I just want to thank all of you for joining us as well. Our hope is for this to be a meaningful and actionable presentation for you. And we are making available the chat feature. So as questions arise, or if you have them right now, please do use that chat feature. We want this to be useful to all of you. And I do want to recognize my colleague who is joining me, Roshni Matthew, who is an expert in pediatric infectious diseases and co-directs infectious disease and control at Packard Children's Hospital. I myself am a general pediatrician. I'm chief of the Division of General Pediatrics, and I do research in health literacy. But first and foremost, I want to thank many of my mentors and leaders and partners in the community. You just got to meet Sherry Sager, who heads government and community relations at Stanford Children's Health and Packard Children's Hospital. Also, a longstanding mentor to both myself and Roshni is Bonnie Maldonado, who is head of pediatric infectious diseases at Stanford University and serves on a number of national organizations that are advising the nation's approach to the pandemic. And Grace Lee, who also sits in the same division as Roshni and who serves with Dr. Maldonado on a national committee that's actually advising the administration of the new COVID vaccine that we're going to be hearing about a lot, not just in the news, but also on today's webinar. And then, of course, Marianne Dewan, who is superintendent of Santa Clara County Schools and the Office of Education, and Mary Kay Going, who has been such a wonderful partner to us and is introducing us to all of you. Our objectives today are to review current evidence-based information on COVID-19 with a focus on children and schools, to review the evidence-based strategies on how to mitigate COVID-19 disease and transmission in school settings, and to discuss authoritative resources and how you and your students and your parents and your colleagues can remain up to date. Our sources are generally evidence-based guidance around the country, mostly from CDC or the American Academy of Pediatrics, but including primary sources from the medical literature. We will not endorse or reject any specific school policy, and all the recommendations that we're talking about should be implemented at your schools in accordance with county health department regulations. I should reference that Sarah Cody is also a colleague of ours, and we really respect all the work that she's doing there. Implementation of all of this is going to be challenging, and evidence will evolve. So first, let's review some information about what we know about COVID-19 among children. First of all, I don't need to tell you this. You're reading the papers, you're seeing what's out there in the news. Kids are being asked to return to school, not just in our community, but across the country, just as the pandemic is surging. There's news up to date in some of the largest school districts, including New York City, about bringing children back to school, taking children out of school. And there's been a lot of op-eds written recently, including by members of our community, pediatricians, really urging schools to reopen just as the coronavirus pandemic is surging. But it's important to tamp down the temperature in all of this to face the facts, namely that the direct impact of COVID-19 on children in the United States is fairly modest. Child cases of COVID-19 are less common, far less common than are cases of COVID among adults. 12% of COVID-19 cases to date are among children in the US. 2% of children have been diagnosed with COVID-19, and younger children seem less susceptible to these infections than older children. And when children do get COVID-19, their cases are often more mild. About 16% of COVID positive children never develop any symptoms. Fewer than 5% have been hospitalized, and far fewer than 1%, actually closer to 0.1%, have died. There were reports early on about a rare syndrome called multi-organ inflammatory syndrome that seems to be associated with COVID, but it's extraordinarily rare. Nonetheless, the direct effects of COVID-19 among children as among adults seem to be affecting much more the communities of color and low-income communities that many of us serve. You can see here that regardless of the age group under 18, Hispanic or Latino communities are more affected by COVID-19, and these are hospitalization rates among children, as are Black non-Hispanic communities. What we are really concerned about in pediatrics actually are the indirect effects of this pandemic on children. That because of COVID-19, we are seeing amplified disparities in mental health, anxiety and depression, in learning loss and achievement that you all care about, and so do we, in financial insecurity and access to childcare for many of the families that we serve, and hunger and food insecurity, which are really disproportionately being affected by many of the layoffs and a lot of the unemployment that has ensued because of the policies put in place to keep this pandemic at bay. And then, you know, Roshni and I are pediatricians, and we care disproportionately for children with special healthcare needs. Children and youth with special healthcare needs actually comprise nearly 1 in 5 of all US children. These are conditions that are often identified at birth, children with preterm birth, children with cerebral palsy. They often have a behavioral component, such as children with autism or ADHD. And these children are disproportionately more likely to live in poverty. As a result of a special healthcare need, they are somewhat more likely to be directly affected by the pandemic. So these children are more likely to carry chronic lung disease or heart disease that makes them more susceptible to the direct effects of the disease. But we also know that children with special healthcare needs are more likely to live in households where the caregivers themselves are at higher risk. They're more likely to have chronic illnesses among adults in their family, and the adults in their family are more likely to be essential workers that are exposed to the disease. So that's the direct risk. But these families are caught between a rock and a hard place, because at the same time that they don't want to send their children back to school because of those direct effects, there are increased risk and need for school services, mental and behavioral health services, food services, social and emotional services, special education services, all these services that you provide to these families, they're missing to. And as a result, it's yet another source of wide inequities. So that's what we know about COVID-19 and its direct and indirect impact on children and families. What do we know about the transmission of COVID-19 in schools? It's probably a big reason why you all are here. Well, we know at a mechanistic level that transmission is a result of 2 large areas that we look at around disease spread, infectious disease spread. One is the community prevalence. So the likelihood of transmission is very sensitive to community prevalence of COVID-19 in the larger community, but also within school transmission and the implementation of mitigation strategies that we're going to talk about in a moment. There are very few case studies of actual transmission related to school or preschool environments in the United States. One of the ones that has been best documented to date in the United States comes out of an outbreak at 2 childcare centers in Utah, where 12 children likely received the illness at the center, and 3 of them did not have any symptoms. 12 people who had contact with the children outside of the childcare centers got infected, including some parents and siblings, and 1 parent was hospitalized. What we know from that experience is that to slow the spread of COVID-19 in childcare centers and schools, we need to double down on all of the things you have been hearing about already. Washing hands frequently, staying at home when you're sick, mask use, and physical distancing, which we'll talk about in a moment. But we've also learned a few other things. Children, yes, can transmit the virus that causes COVID-19. That's called SARS-CoV-2. An 8-month-old was documented from these cases to spread the virus to both parents. And 2 asymptomatic positive children spread the virus to their household contacts. We also know that it's extremely important for both adults and children to stay home if they are sick. The index cases in both of the facilities were staff members who worked despite being household contacts with symptomatic infected individuals. And then finally, that mask wearing is essential. The facility with the most extensive outbreak was also the one that was documented not to require their staff to wear masks. This was earlier in the year when it wasn't as much publicly being promoted, mask wearing. Temperature monitoring and symptom screening alone are not sufficient to prevent outbreaks in these settings, and that kind of came out of the outbreak investigation. We're also learning a lot from outside of the United States, where many children are currently in school. This comes from studies in Asia, Israel, and Europe. We know that social distancing at preschools seems to reduce transmission to household contacts, so abiding by physical distancing in school settings, that masking in school is associated with significantly reduced risk of outbreaks, and that staff-to-staff transmission, not child-to-child transmission or child-to-staff transmission, is mainly the sort of transmission that we see of COVID-19 in school-based settings. In fact, there's minimal workplace risk of transmission in the now thousands of schools and childcare centers that have been monitored over the past year, mainly outside of the United States. This comes both from a US study of greater than 57,000 childcare workers from earlier in the year, but also from a recent study that just came out yesterday in the journal Lancet of a study of thousands of schools in the United Kingdom. So based on all of these studies, what do we know works? We're now going to review the 5 of the evidence-based strategies that are necessary to mitigate the transmission of COVID-19 in school settings. Many of these you've seen before, but we're going to take them into slightly greater detail. So that includes masking, hand hygiene, physical distancing, cleaning, and surveillance. Face masks are extremely important. We've learned more than we knew over the summer about how important they are in reducing the transmission of COVID-19. We originally perceived from some of the historic studies that face masks were important to prevent the wearer of the face mask from transmitting the virus to other people in the environment. We now know that the use of face masks also reduces your risk of contracting the virus from somebody else. We know, of course, that it is difficult to get young children to wear face masks, particularly under the age of 2 years, or to consistently wear them throughout the day. However, what we're trying to do is maximize the appropriate use of a face mask. And there's a somewhat humorous diagram down there of the many ways that I'm sure many of you see people inappropriately using the face mask. And yes, it's very important to have that face mask cover the nose as well as the mouth. And then, of course, we need to think about our special needs students. There are some students, particularly those with hearing impairments or other special needs, who will need to see your masks or see your face, sorry, or your mouth. So there are clear masks that are available for teachers who work with younger students or those with special needs. The second is hand hygiene. Hand hygiene is always important. It's in the 101 lessons for us in healthcare for preventing any infectious outbreak that includes COVID-19. So it's very important for you to continue to teach and reinforce hand washing, especially at routine times of transition. It's important to clean hands with soap and water for at least 20 seconds and use only alcohol-based sanitizers if soap and water are not available. There are many materials, I'll share these with you at the end and through Mary Kay, that are available that are low literacy, multilingual to reinforce this with children of all ages. Now, physical distancing and cohorting are extremely important, and we understand these continue to be very controversial in many settings, including school settings. Much of this comes from what we've observed in other countries and school settings, but also in our own healthcare settings, that physical distancing is important. And just so you know where this comes from dynamic studies of watching aerosolized particles and seeing how far they travel. And so 6 feet is actually a conservative estimate. Most of transmission occurs when it occurs within 3 or 4 feet. But because of this, it's recommended that spacing in classrooms of seating is 6 feet apart, and that you turn chairs to face in the same direction. So for many of you in classrooms that you're used to being in the round or children facing one another, that needs to be modified. It's important to observe this physical distancing, not just in classrooms, but in hallways as children enter and exit schools, and if necessary, transit between classrooms. And so there's a lot of recommendations about how to mark floors and keep flow in one direction. This also applies to other non-classroom settings, including reception and transportation. And there are many recommendations to cohort children where possible. This is one of the reasons why you'll see a lot of recommendations, national and statewide, toward urging schools to start in the early years, the elementary school years, where students are already pre-cohorted. They often stay in the same classroom. They stay in their homeroom and so forth, as opposed to the older years where there's so much mixing and it's so difficult educationally to keep them in the same groups. But it's also why you'll be considering, staggering the school days and so forth, just to keep those cohorts together and to reduce mixing across cohorts, not just of students, but also of all of you, of adults and teachers and so forth. I'm not going to go too much in detail on this. I don't know if there are any folks on the call who are responsible for cleaning the classrooms. This is easier said than done, but the CDC and other international organizations do point out the importance of routinely cleaning and disinfecting classrooms, but also very importantly, and the evidence is rising for this, for improving air ventilation wherever that is possible. And wherever the climate allows. And so we're lucky to live in Northern California where ventilated areas are a little more prevalent than they are actually in the Northeast, but that's certainly important. And then finally, I want to comment on surveillance. There are two general areas of surveillance. One is symptom surveillance and the other is testing surveillance. The most important mechanism we believe and we're observing is symptom surveillance. And just to reinforce the evidence we saw from before, it is extremely important to reinforce among parents, caregivers, and teachers that if anybody is sick, they should stay home. That is the most important message here. And when we say sick, the list of symptoms associated with COVID-19 is only growing. So early in the pandemic, you might remember it was about fever and chills and cough and congestion, sore throat, a lot of the upper respiratory symptoms. But we now know those symptoms can be more flu-like, fatigue, muscle ache, body aches, but also nausea, vomiting, diarrhea. So anybody who's sick should stay home. And there should be careful monitoring for that also during the school day. If somebody starts to feel sick during the school day, they should be encouraged to go home. There's a lot of talk about testing as a means of surveillance. We should consider testing for teachers, staff, or students with clear evidence of COVID signs or symptoms, or exposure to someone who's known to be positive, or if that's otherwise recommended by a health department or healthcare provider. Routine testing of asymptomatic individuals remains somewhat controversial. We are doing that in our healthcare facilities. We are doing that at Stanford University. The utility of that, we believe, is warranted, but there still remains some controversy about that. Where there is not controversy is about this Swiss cheese model. So if you have not seen this, this is the governing model for how we prevent infections. We are not going to put big slices of Swiss cheese around your schools. But what this is really meant is as a model, a visual model to understand how multiple strategies are so important. Just using face masks alone will not prevent transmission of COVID-19 in your school setting. Just doing social distancing will not. And just cleaning and disinfecting will not. But when we combine all of these mitigation strategies together, we know that the aggregate effect is a dramatically reduced risk of any transmission. And that's really what we're going for. We're going to talk about vaccines in a moment. That obviously will contribute to herd immunity and be yet another pretty strong sliced cheese wedge in this mechanism. So finally, some resources, and Roshni is going to add some up-to-date information about the vaccines in a moment as well. As I mentioned before, our go-to resources should be yours as well. They're the CDC and the American Academy of Pediatrics. These are the websites we go to. There are coronavirus-specific recommendations that we go to. We also check in with our county Department of Health. So we also go to the Santa Clara County Department of Health website. But for detailed information and the evidence supporting many of the things that I just spoke about, those are our go-to resources. Locally, Stanford University and Stanford Medicine has worked with a number of providers to enhance testing sites and primary care sites, not just for all of you, but for your students and their families. And we can provide you additional information about this, but these are really meant to provide testing and primary care resources to anybody who needs them. And so we're avidly interested in where you think the gaps are and how we can help members of your community get access to testing and also other healthcare resources. I want to mention one particular resource that we're very proud of at Stanford Children's Health that I actually got my start on many years ago after I finished my training, and that's the Stanford Children's Health Teen Van. It's now celebrating its 25th anniversary under the direction of these wonderful people here pictured. It's a mobile clinic on wheels with exam rooms, lab, and check-in area. It provides comprehensive primary care services. It mainly focuses on homeless and uninsured and underinsured youth aged 12 to 25 years. And it partners with many sites and organizations around the Bay Area and goes out 2 times a week. With generous support from our hospital, including Sherry Sager, we're now exploring COVID testing offerings through this teen van. Since the spring, the van has been offering that COVID-19 testing to its normal population that it serves. And starting this fall and winter, working with local schools to begin to pilot offering these services to youth returning to in-person schooling, particularly those who must be in school due to lack of access to internet or online classes or other reasons. So we're very proud that they're offering that. There are additional resources for parents and students that we've developed here at Stanford. The Stanford Advocacy Program has developed multilingual community resource pages that we provide to all of the patients that touch Stanford Children's Health. That includes not just health services in their community, but food resources, other social services, legal services, work services in the community. We've vetted these organizations. We've called them to make sure that they're open and offering services. And we welcome you to provide similar or partnered resources to the families that you serve. My own lab, my health literacy lab, has developed web-based multilingual services for families with special needs that helps them make an emergency plan, prepare basic home supplies, and also make decisions about whether and how to bring their special needs child back to school. So we have the QR code in the lower right if you want to use it as a back to school guide, where SCOLE stands for Safe Communities of Learning. Families can answer a set of questions and then discuss the results with a trusted advisor like a child health provider if they're concerned about bringing their child back to school. With that, I'm gonna, for a few minutes, hand the stage over to my colleague, Dr. Roshni Matthew, who's gonna talk a little bit about the COVID vaccines that are coming out.
Thank you so much, Dr. Sanders. That was fantastic. I will just take a minute. I just wanted to give you guys a brief look at the lay of the land for vaccines. The FDA actually yesterday approved an emergency use authorization for the Pfizer vaccine, and they are expecting to do the same for the Moderna vaccine. And the vaccine administration to the population at large will be a phased approach. So you may have heard that there are recommendations to who should be getting the vaccination first. And so eventually it will be rolled out, but because of the fact that there is not a lot of a supply yet, it cannot be rolled out to the whole population. The good news is these vaccines have been found to be highly efficacious in preventing COVID infection in the studies so far. This particular slide is from the FDA presentation yesterday. And basically, if you can see the red line that's going up and the blue line that's staying steady, the red line basically is the placebo group of the vaccine trials. These vaccine trials have included about 40,000 patients. I think this one is just the first study, so it's half of it, but this basically the red line shows what happened with COVID cases in the placebo arm, and the blue line basically shows you what happened with the individuals who received the vaccine. So it's a striking difference in the number of COVID infections in the two arms.
Thank you, Dr. Matthew. I just want to say, for those of us who are data geeks, this is an extraordinary slide that really shows how effective or efficacious this new vaccine is. So for those of you, in the future who will hopefully be all of us getting this vaccine, we can be very comforted by its efficacy. That's what this slide shows. And all of the reviews also showing that's a very safe vaccine to get. So thank you, Dr. Matthew. So in summary, we do want to attend to some of the questions that hopefully are appearing in the Q&A as we speak. But these are our summary points, that you as educators, like we, are essential workers, that COVID transmission risk is low in general in community settings, that multiple strategies are necessary to minimize risk, and the county as well as national organizations can provide guidance about how to implement those strategies. And working together through these multiple strategies, we can bring children back to safe communities of learning. So with that, we're going to open up to some of your questions. We're going to look at that. I think Mary Kay was going to select some questions, otherwise I'll look at them. And Roshni and I will do our best to answer them. We do want to mention that this is being recorded, and our intention is to share this recording and other web-based modules and resources with you and others in the county, with hopes that this will be helpful to our partners in education. So questions that we have, I'm not sure who's going to be offering those to us. I actually can view a few of these, Roshni, just so I might just go with them. Should students within the same cohort also remain at least 6 feet apart? So I'm going to do my best, because Roshni and I worked a lot together. So I'll be answering, and she'll be allowed to correct me if I get it wrong. Yes, the answer is yes. Students in any classroom should be urged and encouraged and structurally encouraged to remain at least 6 feet apart. So as an example, some photos I've seen actually from outside the country where children, instead of being in individual desks, are usually seated at a shared table, one of those long tables. You have one child at one end of the table, one child at the other end of the table, both facing in the same direction. That's sort of the model we want to be going after. Roshni, anything you wanted to add to that? Agree?
No, that sounds perfect. 6 feet, yep, that sounds great. Thank you, Lee.
Next question, what are your recommendations for those of us who work with students who are not able to wear masks or social distance, for example, those in special education? Well, I should say that those are the children I care for. I direct our complex primary care clinic where all of our children have special needs. So we talk a lot to the families about this. That is difficult. You can't force them to use it. We are encouraging still the social distancing. All of the other mitigation strategies are very important in those classrooms. So where possible, to continue to observe social distancing, to do lots of hand hygiene and disinfecting in those environments, and to keep those cohorts together and as small as possible. That is essentially what we are recommending there. And also to keep the lines of communication open with families to make sure that they are are comfortable with those mechanisms. I would reinforce that obviously the adults serving those children, the educators, therapists should all be wearing masks themselves. That's incredibly important. And that's sort of my answer to that. Dr. Matthew, anything to add?
No, I think there were several people who had questions around this exact topic. So obviously the source wearing a mask. So if say I have COVID, then it's a good idea that I wear a mask. That is very helpful for source control. But if the children are not wearing a mask and you're unable to social distance, you lose two of the strategies, but there are several other strategies that you would then use. As Dr. Sanders was saying, we care for pediatric patients and we routinely see children who cannot wear a mask or who are too young to wear a mask. So in those instances, I rely on me wearing a mask and I rely on me following hand hygiene and making sure that I follow all the rules so that the risk of transmission is reduced. And then the most important thing is this is a partnership with everybody. So if anyone's sick, they shouldn't be coming to school. So I think that is another important strategy that obviously parents have to be involved in as well.
Yeah, so I'm cohorting the questions, Dr. Matthew. So we're going to talk a little bit more about mitigation strategies, and we'll hold the vaccine questions to the end. I want to make sure we get to the vaccine questions, and I'm going to try to start to cohort them here. One, it has to do with risk groups. So we're going to go to risk groups, and then we'll go back to mitigation strategies. Why is it when children or students are referenced in regard to their lower risk, no one talks about the adult teachers and the adult family, extended family members they go home to? How can these two be separated? So again, I'm going to answer that. And one of the resources that Back to School guide I mentioned references the CDC list of those risk categories as well. We do agree that that is a risk factor that needs to be taken into account. And one needs to be aware of that, that many of the individuals we're talking about, students and other staff, live in households with either older adults or adults with chronic illnesses. And it's important to recognize that if somebody is sick or gets sick at school, we should obviously be reaching out to those individuals as well to keep them safe. Roshni, do you have another perspective on that?
No, I was just trying to understand the question itself because, in the hospital setting, for example, obviously my go-to is what I experience on a daily basis is that the healthcare work, like the adults are the ones that actually are getting infected in the community. The children are many a time not the primary event. So I feel like it's not just the school situation, it's also the rest of the activities that the adults are involved in that places them at risk of acquisition outside of the school. So all of that has to be taken into account as well.
Yeah. By the way, there was a request. I'm sorry for going back on the slides here, but there was a request to repeat the mitigation strategies. And I think that's very important. I'm just going to linger on this one because, again, it reinforces the Swiss cheese model. These are the key mitigation strategies. So using masks, social distancing, disinfecting, and hand washing. And just to remind you that social distancing, of course, is tricky in classrooms and does include the cohorting that we talked about. So these are the key mechanisms. The other two that we talked about had to do with surveillance. So surveillance for symptoms and also testing are sometimes included as mitigation strategies. So for the person who asked that, there were still some other questions about masking though, and I think that's important, Dr. Matthew, for you and I to address. So one of them says, what are your recommendations for those of us, oh, I'm sorry, that's the same, the problem. Middle schoolers aren't even wearing masks accurately. There is no way to cohort bathrooms across a campus. How do you realistically expect this to stay safe? And I just want to pair that with another question about masks. How do you decide which type of mask is necessary, K95, surgical, or cloth? Why don't we take that one first, and then we'll go to the other one. Dr. Matthew, you want to talk about the type of masking?
Yeah, so the regular, obviously there are there are these N95 masks that are highly protective for very specific scenarios though. So in general, those kinds of masks are protective against what we call airborne transmissible diseases. So an example of an airborne transmissible disease is measles or tuberculosis. So those pathogens, so one is a virus and one is a bacteria, they have very specific tendencies that make that kind of mask the most effective mask. Whereas all of the respiratory viral pathogens, so when we talk about influenza or RSV or parainfluenza and all of those, and so SARS-CoV-2 is one of the respiratory viral organisms now. These are effective droplet transmissible organisms. So there is a difference between the two, and that's why the proximity to one another is an important entity, because for airborne transmissible disease, it doesn't matter how close you are. If I am in this room and I have measles and I leave the room and somebody who could get measles, like a very young baby, comes into the room an hour later, that baby could get measles. So that's not the same with SARS-CoV-2. And so that's why the regular face masks are protective against SARS-CoV-2 to protect against droplets. So that's how I would look at masks in general.
The surgical or cloth masks are perfectly
appropriate for regular scenarios, like even crying child or coughing child, or in the hospital setting, we do use N95 for very specific COVID patients. These are patients who are just going to go on a ventilator, for example, and somebody is going into their airway, that person wears an N95. But in general, even when we care for COVID positive patients, we could safely actually take care of them with a regular surgical mask.
Right, and that's common, I just have to say, in primary care as well. So surgical or cloth masks are fine. There are similar questions about...
Lee, I'm sorry, I'm going to interrupt. We're down to the last 2 or 3 minutes.
Okay.
And I want to give an opportunity to Dr. Going and Dr. Dewan if they want to make any last comments, besides thanking both you and Dr. Matthew. We will continue to try and answer the Q&A. One of the questions that has been asked is, will we make the slides available? And we are recording this, so we will be making the webinar, the whole webinar, available as well.
Great.
So any last comments by Dr. Sanders and then Dr. Matthew, and then we'll turn it over to Dr. Dewan and then Dr. Going.
Right. I'll just say, well, first of all, I want to thank everybody, including you, Sherry, and Dr. Matthew, for joining us. That we will endeavor, we're going to capture all of these questions, and we will endeavor to provide written answers to them back through Dr. Going where we can, and it will also inform future educational offerings we provide. So thank you for all of that. I'm just going to trust my colleagues here that we can capture it and not lose these questions, because we really do want to be responsive to your questions. So thank you with that. Dr. Going.
Great. I just wanted to thank all of you for being here. We are just so thrilled to have you, Dr. Lee, and Dr. Matthew and Sherry as a team of people to help us get a better understanding of the science behind it. I also want to thank Dr. Dewan and the County Office of Education for their continued support of this work and the work that we're doing in our district. And I want to thank all of the county office participants for joining us as well today. We are thrilled that this is videotaped, because while this is language that you live with every day, this is a lot of new information for us. So that's going to help us to be able to review this information when we have questions that crop up again. And with that, I'll turn it over to Marianne for any comments you'd like to say.
Great, thanks so much, Dr. Going, and for our partnership and the partnership with Stanford, Dr. Sanders and Matthews, Sherry Sager, and everybody on the team. I also just really want to thank all of the educators and school personnel. I know it's been an incredibly challenging year, and it's almost over. 2021 is coming soon. But I just would be remiss if I didn't thank you all for your incredible efforts and hard work, and for raising, the questions and concerns that you have, and giving us this opportunity and partnership to work with the experts and to bring more information to you and to the forefront. Just thank you all.
With that, thank you. Sherry, I know we got a little taste of what our teachers go through every day. So from behind the scenes. And so we have a new appreciation for all that you do, and have a wonderful afternoon. And we're
Absolutely.
done.
And thank you from all of us. And thank you for bearing with us as we worked out the glitches. So
all right.
thank you so much. And thanks for what you do every day. Have a good afternoon.